Good evening, everyone. My name is Jen Nolan. I'd like to welcome you to the 5th webinar in our 2016 Musculoskeletal Health webinar series. But the first webinar as we transition to Move Muscle, Bone and Joint Health, the new dynamic voice of arthritis and osteoporosis Victoria. Move's purpose is to improve the quality of life of people who have or are at risk of developing muscle, bone and joint conditions. This evening's webinar will cover the diagnosis and management of lupus. Before introducing our presenter for this evening, however, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties, please refer to the message box on your screen. You can type a message for the organiser at Redback Conferencing at any time. If you're listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of his presentation, you can actually type questions for him at any time. Can I suggest you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. I'd also be very grateful to all participants if you could take a moment at the end of the evening's presentation to answer our exit survey. It should only take you about 30 seconds. Our presenter for tonight is Professor Eric Morand. Eric is founder of the Monash Lupus Clinic, Australia's only multidisciplinary lupus clinic and home to the country's largest lupus clinical research group. He is also Director of Rheumatology at Monash Health, Australia's largest health service, and Head of the School of Clinical Sciences, Faculty of Medicine, Monash University. Without further ado, I'll hand proceedings over to Eric. Thanks very much, Eric.
Thanks, Jen, and it's a pleasure to be involved, as usual, with MOVE and to help in your mission to spread quality information about rheumatic diseases to the public and to the people who care for them. So I was asked to respond to some specific topics tonight, and I'll endeavour to do that. I've got quite a lot of slides, but really I'm hoping to be as broad as possible in the presentation, and hopefully that meets the needs of the audience. And if there are specific questions, please do note them down and send them through at the end so that we can try to answer them for you. So firstly, my disclosures. I receive research funding from the NHMRC in Australia, the Lupus Research Institute in the US, and also from Arthritis and Osteoporosis Victoria, as well as from a number of other organisations. And I also have advisory roles to some organisations involved in drug discovery in the lupus area. So my mission tonight is to discuss recent highlights in clinical and fundamental research in SLE and outline the implications of this research for the diagnostic and management approaches of these people within person-centred care. And I'm going to start by doing what I hope is forming a bridge between current knowledge that some of you may have in reference to arthritis and what we know about lupus. So I'll show the next few slides just to talk about rheumatoid arthritis, and then I'll show how lupus is similar and yet different to that disease. So the normal joint that you can see, let's see, I'm hoping I can use this pen here. The normal joint is the connection between the two bones, and the space between the bones is normally a bland fluid and a lining layer of cells around the outside that's extremely inactive in normal conditions. Now this picture shows a histology slide of a finger joint of a human, a normal human joint, and you can see here that this cartilage area is very bland looking, and the joint tissue out to the side here is very bland looking as well. Contrast that now to the appearance of rheumatoid arthritis, where the synovium here, which is the joint lining tissue, is absolutely jam-packed full of white blood cells, compared to normal synovial tissue here, which has got a lot of spaces in it. Some people describe it as being lacy because of those spaces. In rheumatoid arthritis, any potential space is absolutely jammed full of white blood cells. And the white blood cells are the agents, or soldiers, if you will, of the immune system. Now, if you look into a knee joint of a rheumatoid arthritis patient over time, this is the cartilage of a normal joint, with a normal amount of blood flow here in the synovial tissue. Over time in rheumatoid arthritis, this tissue here becomes inflamed. You can see that first with this extreme redness shown here in this early arthritic joint. This red tissue of inflammation then becomes overexpanded to these kind of coral-like fronds of tissue that you can see here in late stage. And then in advanced stages, you can see this very destructive process where the joint cartilage itself becomes destroyed. And what this picture shows is the journey from normal tissue, which is cool and bland, through inflammatory tissue into damaged tissue. And in chronic inflammatory disease, that's the journey that we see from normal to inflamed to damaged. That's in rheumatoid arthritis. So what is the cause of rheumatoid arthritis? Well, rheumatoid arthritis is caused by malfunction of the immune system. And to break this down to its simplest level, the immune system is made of white blood cells, and I'm showing these here in several colors because there's a lot of different types of white blood cells that have different functions. And these white blood cells make antibodies. And antibodies are proteins that circulate in the blood, normally that protect you from disease, and you will all have antibodies against infections that you've been vaccinated for, and these are protective antibodies, but you can have antibodies that are harmful too. So normally white blood cells and antibodies are there to defend you against germs, but if they are directed against your own tissue, they can cause disease. And in rheumatoid arthritis, that disease is the inflammation of the joints that I showed you before. Now, we now know a lot more about rheumatoid arthritis than we used to. This looks like a very complicated drawing, but I don't want you to focus on how complicated it is, but just on a simple explanation that I'm about to give you. These antibodies shown as these little Ys here, in the blood of patients with rheumatoid arthritis, we now detect in blood tests with a test called the ACPA or CCP blood test. And these antibodies really now make a diagnosis of rheumatoid arthritis in about 75% of cases. It turns out the reason people have these antibodies is mostly because of air pollution, and the most severe form of air pollution you can get is to smoke. And so smoking triggers these changes in the immune system such that these antibodies are made that aren't normally made, and these antibodies deposit in the tissues and cause inflammation. Now, why is this important for us to know? It's important for us to know because we now have treatments that are addressed specifically at some of these areas of the disease. So, for example, the drug rituximab is a drug which attacks the B cells, which is one of the types of white blood cells, particularly is involved in making antibodies. And so this drug, rituximab, is effective in about 60% of patients with rheumatoid arthritis because it attacks some of the cells that are causing the disease. And another type of drug in rheumatoid arthritis that's very effective is the anti-TNF drugs like Humira or Enbrel, and these work by attacking this molecule TNF. So what we have now in rheumatoid arthritis is a situation where over years of research, discoveries of some of these mechanisms have led us to be able to develop new treatments which are highly effective. What are some of these new treatments? Well, here's a list of some of the drugs that have been tested and successfully proven to be effective in rheumatoid arthritis. These are now very specific treatments that, although they have some risk of side effects, are generally very well tolerated by patients and are associated with a great improvement in patients' outcome. And these changes in outcome are shown in this graph from a recent paper published in the journal Rheumatology. And I'll just take you through it because I think it's very interesting to contrast to the situation in lupus. So this is a graph from 1989 through to 2008 in a large number of patients in a British data registry. And what it shows here is the percentage of patients taking the drug methotrexate over time, going from 0% just before methotrexate came in to now about 60%. And here, about 10 years later, is the percentage of patients taking drugs like the anti-TNF drugs and rituximab that I showed you before. And on the right side of the graph, what this timeline shows is the amount of joint damage progression that patients in the same clinics experienced over time. And you can see a slope in the opposite direction in this graph. showing that the introduction of more specific and effective therapies in rheumatoid arthritis led to reductions in the amount of joint damage that patients experienced. And we now know that to be the case in rheumatoid arthritis. So what have we learned in rheumatoid arthritis? Studying the biology of disease has led to great new treatments, and the majority of patients now have a great outcome with rheumatoid arthritis, although there's still lots more work to be done to make that the case for everybody. And measurement of patient outcomes using accurate clinical measurement has been a big part of that story of making things better for arthritis patients. So I've talked about rheumatoid arthritis because I hope that might be quite familiar to a number of people in the audience who deal with patients with musculoskeletal disease. And as an example of understanding how the immune system can cause disease and how learning about the immune system can lead to improvements in treatment. So what about lupus? Lupus is in some ways a similar disease to rheumatoid arthritis. We have abnormal activation of white blood cells and the production of antibodies. However, in lupus, these antibodies cause damage in just about every organ system of the body. So lupus does affect the joints, just like rheumatoid arthritis does, but lupus can also affect just about every other organ of the body, including the heart, the lungs, the brain, the kidneys, the skin, the bone marrow, the spleen, the liver. Really just about every organ can be affected by lupus, just as shown in this diagram. So the similarity to rheumatoid is that it's caused by the immune system, and the difference is that rather than just affecting the joints, it can affect multiple parts of the body. Unfortunately, I can't show you a graph like I just did in rheumatoid arthritis showing how much better people are doing. This is a graph showing the mortality of lupus patients in the period 1970 to 2005. And the period that I showed on that rheumatoid arthritis graph from about 1990 starts around about here. Now, from 1970 to 1990, there was a great reduction in the average mortality of people with lupus. In other words, people with lupus were dying less often during that period. That's with the introduction of high-dose steroid therapy and some other things that we still use to treat lupus. But as you can see, in the period since about 1990, there's been basically no change in the outcome of patients with lupus. And in fact, the standardized mortality ratio of lupus patients sits at about 3.4, which means that on average a lupus patient is 3.4 times more likely to die at any given time than a patient in the normal population. So in this period since 1990, as I showed you, outcomes of rheumatoid arthritis are getting better and better and better. In the same period of time in lupus, patient outcomes have not changed at all. And I'll remind you that this is a mortality graph, so this is showing patients who die. What are the things that predict death of patients with lupus? Well, organ damage is measured by this thing called the SLIC index, which is a tool to measure the effects of lupus over time on a patient. And what you can see here is that patients' survival, if patients don't have significant organ damage, is pretty good, out to 25 years after diagnosis. But if patients do have organ damage, you can see that by 15 years, the mortality rate hits about 50%. And that means that a patient diagnosed with lupus, if they have bad damage, has a 50% chance of dying 15 years after diagnosis, which is a pretty terrible state of affairs, especially seeing lupus is usually diagnosed in young adult women aged between 20 and 30. So we still have a major problem to address in lupus to make patient outcomes better, because unfortunately people are still losing their lives. So I've shown you that mortality rates are there, and that organ damage is a strong predictor of mortality. This graph shows how patients gather damage over time. This was a study from Canada looking at patients during the first 20 years of their diagnosis, and as you can see, unfortunately there's an inexorable trend towards more damage over time in patients with lupus. And this graph from another study, it's a little bit complicated, but basically shows that people with more disease activity have more damage than people with less disease activity. So what does that all mean, summing up? So we should understand that SLE is like rheumatoid arthritis in that it is a disease of the immune system causing harm to the body. But unlike RA, it's a multi-system disease where multiple organs can be affected. And as a result of that, patient outcomes in lupus are still poor, where patients have active disease which leads to damage, and damage which leads to loss of life expectancy. Now, the fact that lupus is so much more complicated than rheumatoid also means that measurement is much more complicated. And I'm going to spend a few minutes now talking about some areas of research that we think are helping with this measurement question. I'm just going to pause for a second and ask Jen for her advice, because I can see that one of the participants has sent in a question a couple of minutes ago. Jen, if you're on the line, should I answer these questions as we go?
It's up to you, Eric.
Yep.
If you would prefer to wait till the end of your presentation, we can do that. Or if you'd like to answer questions as we progress along, totally up to you.
Okay,
Whatever
thanks.
you prefer.
All right, well, I might do them as we go then. So Margaret has asked a question: can a male 52-year-old diagnosed only with skin lupus progress to have other organs involved? That's a great question, Margaret, and a question that a lot of patients do ask. I'm just going to have a sip of water. So systemic lupus, SLE, is diagnosed when multiple organs are affected. There's another condition called discoid lupus, which is a specific lupus type disease that affects only the skin. So if your patient has discoid lupus, sometimes called DLE, usually diagnosed and treated by a dermatologist, then that patient is not likely to have progression to multiple organ involvement. If the patient has SLE, which is to say that they already have effects of multiple tissues, then a person with skin disease can progress to have other organs affected. The most likely time for that to happen is in the first few years after diagnosis. So if a patient's had lupus for many years and never had severe organ involvement, the chance of severe organ involvement is low. Unfortunately, not zero. Patients still can develop that over time, but the longer you've had lupus for without serious problems, the more likely it is that you won't have serious problems. And the next question is from Efthalia. I'm sorry if I haven't pronounced that right, Efthalia. And the question is lupus hereditary? That's another great question, and the answer is partly yes and partly no. Lupus is not hereditary the way that strongly genetic diseases are. Some genetic diseases are inherited directly from the parent in a one-to-one way, and so the offspring of patients with those genetic diseases all get the same disease. Lupus is not like that. It's not inherited in a direct way. But family members are more likely to be affected. So if the prevalence of lupus is about 1 in 1,000, about 1 in 1,000 people in Australia have lupus. And the lupus incidence in primary relatives, so brothers and sisters or mothers and fathers, is about 10 times higher. So 10 times higher is a very significant increase in risk, telling us that genes are definitely involved in lupus. However, 10 times higher from 1 in 1,000 is still only 1 in 100. So family members of lupus patients are much more likely not to get lupus than they are to get lupus, even though their risk of lupus is higher than the general population. I hope that that's helped clarify, and if not, I'm happy to take further detail on that question. Okay, so moving ahead now into the main mission for the night, which is to talk about how does research make a difference to patients, and what can we help our patients understand about the state of the art in lupus research, and what difference will it make to them. And I'm going to do this in 3 areas. First, talking about clinical research, then talking about fundamental or laboratory research, and lastly talking about research into new treatments. So what are the issues in clinical research in SLE? And one of the main issues is how better to measure treatment response in clinical trials. The second component of that is, can we have a treat-to-target approach in SLE so we know how good our patients need to be? The third is, why do we still use steroids in patients with lupus? And the fourth is to talk for a moment about patient-reported outcomes, which may be quite interesting to the audience for tonight's seminar. So in relation to the first 2 questions about how do we measure treatment response to lupus, sounds like it should be easy, right? how to measure whether a patient is getting better sounds like should be the easiest thing in the world. Well, the trouble is in lupus, because as I showed you, it's a disease that can affect multiple organs, it's been very difficult over the years to develop a way to simply measure how patients are doing with SLE. So I'll show you an example of one of the ways that we measure disease activity in SLE. This is called the SLEDI, SLE Disease Activity Index. And that's the measure that we use in our clinic at Monash. If you can't read it, don't worry, but the purpose of showing this figure is just to show that there's a series of outcomes that we ask patients about, and each of those is associated with a numerical score. So for example, if you have arthritis, that's worth 4 points. Excuse me. If you have a rash, that's worth 2 points. If you have mouth ulcers, that's worth 2 points. And so you add up the score of all these things and you get to a total score for that patient, which might be 8 or 12 or something like that. It takes a few minutes to collect this information and come up with a numerical score. The trouble is that, let's see if I can make this go away, if I can rub that out or not. Oh, it doesn't look like I can. Anyway, the point I was going to make was that the trouble with this score is that a person with arthritis, oh thank you, someone's made that go away. A person with arthritis could have a score of 4. A patient with blood in the urine could have a score of 4. So that's 2 different patients with the same score. So if you're comparing patients and you have 2 patients who've got a score of 4 using this scale, you might think that those patients have got similar disease activity, but actually they haven't, because one has got joint disease and the other has got kidney disease. So this particular measure is good because it's simple, but it probably is a bit impaired because it's a bit too simple. The solution to that is shown on this score, which is called the BILAG, the British Isles Lupus Assessment Group Index. And as you can see, this is a much more extensive type of measure. Please don't try to read what's on this slide. I haven't put it there so that you can read it. I've put it there just to show you how complicated it is, because on here there are, I think, about 90 different scores to be completed for each patient at each visit. The advantage of this scoring method is that it doesn't miss anything, but the disadvantage is that it's very difficult and time-consuming to complete, needs quite a lot of training to complete, and actually is very hard to do accurately. So the complex nature of lupus has made it very difficult for researchers to come up with ways to measure disease activity. Why is it so important to measure disease activity in patients? Well, we know that in diseases where we measure things accurately, we can make a difference. Here's a slide from a paper from some years ago now, looking at the treatment of blood pressure. Now, blood pressure is an easy thing to measure. It's a number. You measure it with a machine or with your blood pressure cuff, and that is the patient's blood pressure. Nothing could be more simple. Now, if you treat patients with high blood pressure using a strict protocol where you aim to have patients reach a target blood pressure, then this is their rate of developing complications such as heart attack or stroke. Compared to if you don't have a strict protocol and just let patients be treated any old how, they have a much higher rate of developing complications like a heart attack or stroke. So what this shows is that if you have something you can measure and you use that measurement to dictate your treatment, you can get better outcomes for patients preventing stroke and heart attack. Now that's in blood pressure, which is easy to measure. It's just a number. But actually we now know the same is the case in rheumatoid arthritis. We can get a number for patients with rheumatoid arthritis by counting the number of swollen joints or counting the number of tender joints and calculating a score based on those simple numbers. And without going into detail about these trials, each of these 3 trials showed that if you looked at patients who were treated using their score versus patients not treated using their score, the outcomes were superior when the score number was used as a way to drive therapy. This was in clinical outcome, this was in X-ray changes, and this was in damage accrual. So these 3 trials did not use any new drugs, no new therapies, just used measurement as a way to drive prescriber behavior. And treating to target is what this is called. Treating to target yields better outcomes in rheumatoid arthritis. So that means that we know that in many fields of medicine, measurement of the disease activity is very important to get good patient outcomes. So how can we do that for lupus, which is so complicated? Well, a large group of researchers, which includes myself, have been working for a few years now on this treat-to-target idea in lupus. Now, the trouble is that lupus is so complicated that coming up with a good way to measure these outcomes has proven to be really quite hard. But there's a bit of movement in the right direction in that regard, and I do want to share that with you. So the idea is that lupus is very heterogeneous because of these different problems that can happen. So a patient who's flaring with active lupus could have rash, arthritis, and mouth ulcers, or might have kidney disease and heart disease and blood problems, or might have brain disease and blood vessel inflammation. And these three patients look very different to each other when their disease is active, and this has made it very hard to measure. But the new idea here is that as patients' disease activity lowers, they actually become more similar to each other. The heterogeneity or variability decreases as the treatment works. And so a patient who is doing okay can actually be identified relatively simply. And to put that another way, here's a graph of two patients' disease activity measured over time. This is that SLEDI instrument that I told you about before. And you can see a patient's going up and down, up and down, up and down over time using this number. If we set a low disease activity threshold here at this number 4, then we can actually work out that this patient never got below that level. They did not reach the target. Whereas this patient spent quite a bit of their time below that level. In other words, they did reach their target. And so the ability to measure a treatment target outcome in lupus is now looking possible. So on the next slide, I'll just show a definition that we've recently published for a low disease activity state for lupus. So that looks like I've crossed it out. I meant to underline it. I apologize. Don't worry about the details here, but basically we've had the idea of an amount of disease activity that is acceptable and an amount of treatment that is acceptable to tell the patient that they are doing okay. And we've now shown that this measure is associated with protection from damage accrual in patients with lupus. So just like in high blood pressure, which I showed you before, and rheumatoid arthritis, which I showed you before, having a measure of treatment outcome helps physicians to drive patients towards that outcome and be associated with good results. Now I see there's another question from the audience here, from Margaret, and the question is, are GPs adequately trained to diagnose SLE and DLE, or is a specialist referral needed? We would usually say that when the question of SLE arises, the patient ideally should be reviewed by a specialist such as a rheumatologist. The complexity of lupus and its treatment is such that we do think the diagnosis should be made by a specialist. And one of the problems is delay in diagnosis leads to delay in treatment, and that can lead to worse outcomes for patients. So if the patient's under good control with treatment from their GP and everybody's happy, then that's fine. But if there's a question of does this patient have SLE, then we do recommend that a rheumatologist or other specialists be involved in that. Okay, now back to the slide. Why do we include in this definition of low disease activity the dose of steroids? Why don't we just talk about the disease activity itself? Well, steroids are used in a lot of patients with lupus. As this slide shows from the Johns Hopkins Hospital in Baltimore, a very large study of 525 patients. I'll just hone in on this particular part of the graph. They looked at patients on their very first visit to the clinic, and 50% of patients were taking steroids at the first time they arrived in the clinic. Now that is a lot of patients taking steroids. When you look at the patients over time, the patients not taking steroids by year 5 is only 28%, and by year 10, only 15%. So patients are more likely to take steroids the longer they have the disease. The exact opposite of what we would hope, which would be that more patients will be taken off their steroids. What we see, unfortunately, is that more and more patients are treated with steroids. And we see exactly the same in our clinic at Monash. This is a study from a little while ago where we looked at 184 patients with steroids, and we found that 138 of them, or 75%, had been treated with steroids at some time during their 3 years follow-up, and the cumulative dose of steroids was 7,500 milligrams over that period of time. And any of you who are familiar with the use of steroids would know that that's really quite a lot of steroid to take. The mean dose, as you see here, 8.4 milligrams a day. So steroids are used a lot in the treatment of lupus because better treatments than that are not yet available. Anyway, the point of saying all this is that the amount of steroid that you take is actually associated with the amount of organ damage that you develop. This is this damage index that I mentioned before that's associated with active disease. It's also associated with the cumulative prednisolone exposure. And what that means is that having active lupus is bad for you, but taking steroids to treat that lupus is also bad for you. So patients with lupus are really in a very difficult position in relation to these competing agendas. So what's the take-home here? Measurement in lupus is very complicated, but has got to be better. We've got to have measurement because we know measurement drives better outcomes for patients across all kinds of diseases. But more work is needed to get better and better ways to measure lupus disease activity. One of those good ways could be the way to measure low disease activity. And we think this could be a measure that can be used in clinical trials and in everyday practice. And by using these measures to drive better treatment, we've got to get steroid use down in lupus because it's causing problems. Now, what about patient-reported outcomes? So all the things I've shown you so far, these disease activity scores and so on, are scores that are completed by the treating doctor. They focus on organ inflammation, such as the presence of arthritis or rash, etc., and on lab tests, such as the presence of low blood count or hematuria, protein in the urine, etc. And this is the sort of thing that the physicians measure in their clinical encounter with the lupus patient. The question is, does this capture what the patients experience? So a lot of work has been going on in the last few years to look at patient-reported outcomes in SLE. So there's this acronym here, HRQOL, which stands for Health-Related Quality of Life. And health-related quality of life deals with things like emotional health, pain, vitality, body image, and general health. And then there's non-health-related quality of life, such as coping, social support, and satisfaction with care. Now, you don't see any of these things on those disease activity measures that I've already shown you that we use to measure lupus. But we know these things are incredibly important to our patients. And we've actually studied this in Monash and found that the things patients care about are actually quite different to the things that physicians care about. And this gives us really pause for thought in our management of these patients. Are we really measuring the right things? So one way to try to get to that is something called the Lupus Impact Tracker. And as you can see here, it's scoring things that patients care about. I woke up feeling worn out. I'm anxious, I'm depressed. I have difficulty concentrating. My medicines cause side effects. It turns out that these are the things that patients actually worry about most. And patients can give a score on this instrument to the things that they care about, and we can add up a total score for how the patient feels about their disease. Now, we've done this at Monash in a small subset of our patients, and here are the scores that we get in these various domains. And in these measurements, a low score is bad. So the presence of these low scores means that patients are not doing well in relation to these domains. Now, it means that the quality of life of our lupus patients is not good. Now, what this slide shows is a correlation between this patient-measured outcome, the LIT, and the doctor-measured outcome, the SLEDAI. And for each patient, Each dot is a patient, and it plots a relationship between the two on a graph. And what this graph shows is that there's no correlation between what the doctor thinks is going on and what the patient thinks is going on. Now, that's a pretty serious thing to discover that the things the doctors are measuring in their patients are actually not the things that the patients care about. And this is really a pretty devastating piece of information for someone in my position who's been treating lupus patients for 20 years, to discover that the things that we care about and we measure are actually not the same things that the patient cares about. So we now know that measurement in lupus has to reflect the patient outcomes as well as the physician outcomes. And the lack of correlation between the physician measure and the patient-reported outcome means that the patient-reported outcome is measuring something that we physicians are missing. So more research is needed into how changes in patient-reported outcomes might tell us which medicines are good medicines. Now, the analogy here, again, back to rheumatoid arthritis, is that the anti-TNF drugs now used widely to treat rheumatoid, the first things patients will tell you when they start these drugs is not that their joints are less swollen or less painful, but just that they feel better. They have more energy, more vitality. Now, we don't have good ways to measure that in arthritis patients, but the patients will tell you this time and time again. Now, in lupus, we need ways to measure treatment success that include measuring the things that patients care about, and that's something that we still have got a lot more work to do on. Okay, I might pause there and see if anyone wants to submit any questions about this measurement question or about anything to do with the clinical research in lupus. Because I'm going to move for the next 10 minutes or so into some different areas. If no one's typing any questions, I'll move on, but I'll keep my eye on that part of the screen and come back to questions as we get them. Okay, so now in the second of the three areas of research that I want to deal with, I want to talk just for a couple of minutes about what's happening in the fundamental science of lupus. So, I've talked already about how lupus patients can be very different to each other, how one patient could have arthritis and rash, another patient could have brain disease or blood disease, etc. We label these patients with the same diagnosis of SLE, but this label is really now probably proving to be inadequate to capture the complexity of diseases. We now know that patients with lupus are actually quite different to each other, shown in this picture just with different colors. They actually have different immune molecules in their blood from one patient to the next. But we treat all lupus patients the same, with the same medicine. And as I've already shown you, a lot of the times that is with steroids. So we have patients who are different to each other in biology terms, but we're giving them the same medicine. So maybe it's no surprise that the outcomes are not that good. What most of us now think we need to be doing in the future is separating this mixture of patients out into individual subsets based not on whether they've got rash or not, but based on the exact molecules that are present in their blood, so that we can take patients with molecule A and give them medicine A, or patients with molecule C and give them medicine C. And that is called targeted treatment, sometimes called precision medicine or personalized medicine. And this is where the field is going to be going, and I want to spend a minute or two talking about that because I want to use it as a way for us to be extremely encouraging to the patients that we're looking after, because I truly think that there is light at the end of the tunnel in terms of how we're going to help our patients. So, how to measure these different colored lumps. I won't spend much time on this because it's incredibly complicated, but if people are interested in reading about it, this paper came out in the journal Cell just a few weeks ago. For the first author was Blanchero, and it was really one of the biggest breakthroughs in research in lupus that has ever happened. And what they did is they took a large group of patients with lupus, and they took their blood cells, and they did a lot of measuring of gene expression in the blood of those patients. And they compared healthy patient genes to lupus patient genes. And then they measured a variety of other disease variables, such as the things I've talked about. Excuse me. And then they, excuse me, wait a second. Excuse me. Then they took this data and put it into a system that we refer to as informatics, which is basically extremely sophisticated statistics, and were able to come up with different groups of patients, which they've color-coded here. If I just go back one slide, you'll see I've used these color codes on this slide to show that there are different subsets within the group of people that we call lupus. And this very complicated biological and computer-assisted analysis is starting to show us that there are indeed biologically distinct groups of patients within a cohort that we would call lupus. So we might end up having to have different names for these diseases once we know more about them. How does that look? Here's some data from our clinic at Monash where we've measured some immune system proteins in about 6,000 serum samples from different patients. And here's a whole bunch of proteins that we've measured in the blood of these patients. And this picture here shows what's called a heat map. Red is strong and pale yellow is weak, showing that some of these proteins are very strongly related to each other in terms of how what the level is in the blood. And when we take what's called an informatics approach to that data, this is looking at about 60 individual patients' time course, and this heat mapping approach basically color codes the data, and I want to show you how this very sophisticated technique actually makes things very easy. Because in this big blue area here, sorry, there's a background announcement in the hospital where I am. I'll just wait for that to go. It takes all the patients with this similar pattern here, and they come up as blue. But just over here on the left, you can see that these patients aren't blue, they are yellow, which means these patients, the computer tells us these patients have got different proteins in their blood compared to all these patients over here. So this little group of patients here have got a different colored biology to this big group of patients here. And we have to find out exactly what the proteins are in these patients, and then we could give them a medicine that blocks exactly the proteins that that patient needs. Now, this is from this paper that I mentioned before that came out just a few weeks ago, and don't be worried about the detail here, but it's the same type of analysis. Healthy patients here, when you measure 15,000 gene products, 15,000, you need big computers to do that. All the patients have this matching kind of yellow pattern. And in the lupus patients here, in this big yellow area, there's this area of red. And that means that all of these lupus patients have got a protein in their blood here that none of the healthy patients have got. And that is going to tell us something very important about lupus that might give us a molecule to go and make a treatment against. And this is the first time really that this type of research has been able to be done because it requires extremely powerful computing as well as extremely powerful assay technology that can measure 15,000 gene products at once in 972 samples. So that's about 1.5 million results. And there's really no way the human brain can cope with that much information. It's got to be analyzed by sophisticated computer technology. And what that technology does is that it actually applies color codes to individual patients. And so you can see this patient has got these colored modules suggesting certain types of immune proteins in their blood, and that's quite different to this patient over here that's got some different color codes. And the software spews out pictures that look like this, which show that different molecules are in one patient compared to some other patients. The detail here is not important, and to be honest, I sort of struggle to understand it myself. So complicated is the computer science that leads to this. But the bottom line is that the heterogeneity of lupus that I've been talking about so far might actually be the wrong construct. Now, I just want to get off the phone for a sec because I can hear a vacuum cleaner approaching the room that I'm in, it's going to get in the way of this broadcast. So I'm going to disconnect for just a second and close the door. I'll be right back.
Ladies and gentlemen, please stand by. We'll be resuming in just a moment.
Okay, sorry for that interruption. It's that time of night when the hospital's being cleaned. So anyway, the bottom line here is that lupus may be several different diseases with different biology. And this scientific approach using sophisticated computers is called a big data approach. And it's going to make a difference to how we treat lupus. And the message I want all of us to take to our patients now is get involved, because we need the cooperation of large numbers of patients to donate their blood and cells to help us do the sort of studies that we need to take this to the next logical conclusion, which is better treatments. So now in the last couple of minutes, I'll finish with how this research is actually making a difference to patients with new therapies. Unfortunately, there have been a lot of treatments trialed in lupus that have failed. And here is a list of some of the drugs that have failed in clinical trials in the last 5 years in the treatment of lupus. And these drugs have generally been given to lupus patients all in a bunch, instead of lupus patients subdivided into these biological subsets that I've just been talking to you about. So we now think we know why so many of these drugs have not worked in clinical trials. Now, some have worked. And this drug, belimumab, also known as Benlysta, is available now for lupus. It's a drug that is a specific antibody against a protein that's relevant to antibody production in lupus patients. And this graph shows the results of a clinical trial showing that patients on placebo, 32% of patients got better, compared to patients treated with the drug, 52% of patients got better, proving statistically that the drug is more effective than placebo. Unfortunately, the difference between 32% and 52% is not a very big difference, and so the drug has not been gangbusters in terms of helping thousands and thousands of patients. But still, it's on the market now, and that means that it's possible to develop drugs that are effective in lupus. And that in itself is a breakthrough, because this drug is the first new drug approved for the treatment of lupus in over 50 years. Now, unfortunately, not every drug that targets that has worked. This is another drug against the same molecule, which worked in one of its trials but not the other. This drug is not coming to the clinic, so we've still got better work to do. But I want to show you this picture from a paper which just came out a few weeks ago of a new drug blocking a protein called interferon. Excuse me. And interferon is one of these subsets that I've showed you before of patients with lupus. If you block this molecule interferon, you can take patients with lupus skin rash and make the rash go away. Shown here on the chest wall of a patient with lupus, and here on the fingers of a patient with lupus. And there's some considerable hope that drugs targeting this molecule could be the next breakthrough in the treatment of lupus. So, what are the take-home messages for new therapies? Unfortunately, there have been failures, which has been discouraging for us and for our patients. But each time there's a failure, we get together and try to learn what it's told us about the disease and what it's told us about how to measure the disease. So step by step, we're getting better and better at studying lupus and learning how to make better treatments. So what do we tell our patients now about clinical trials? Well, if it was easy to make treatments for lupus, it would already have been done. Unfortunately, it's hard to make treatments for such a complicated disease of the immune system. But most of us think that now, with these breakthroughs in laboratory technology, computer technology, etc., that have really only been possible in the last couple of years, we really do think that there's light at the end of the tunnel, and that new effective treatments for lupus are just around the corner. Many trials are ongoing. There's more trials for lupus in the world now than at any time before in history. So scientists and drug companies too are now starting to understand that the breakthroughs in lupus could be just around the corner, and there's a lot of research that's happening. So I would encourage you to tell your patients to be in contact with an academic medical center and consider joining in a trial, because to get these treatments tested and approved, it takes an effort that includes collaboration with our patients as partners. So I'm going to stop now and leave 10 minutes for any questions with a summary of the presentation that I've done. Firstly, SLE is an immune disease just like rheumatoid, but it is more complicated, and the riddles of lupus are harder to solve. Improvements in measurement for lupus are urgently needed, and we need to be able to use patient-reported outcomes when we assess a patient, so we know how they feel and how the disease is affecting their life. We've got to use less steroids in the treatment of lupus patients because they, although they're effective for treating inflammation, they do significant harm as well. The good news is that technology is fueling new discoveries that we really believe are going to fuel the discovery of new treatments, even though some clinical trials have failed, and that's been very sad for the patients involved as well as for the scientists. More are on the way, and we really do think there's light at the end of the tunnel. So with that, I'll conclude, and there's about 10 minutes left according to my clock to take questions from the audience. So I can see one question now from Anna, and her question is, what would you advise to a patient who's had 4 miscarriages with lupus? Are there trials for pregnant women? Okay. Just for people who aren't aware of this, so there's lupus mostly affects young adult females, aged between 18 and 50, and these are the fertile years. Lupus is 9 times more common in women than in men. And so managing lupus through the childbearing years is a major issue for patients with this condition. Some patients with lupus have very successful pregnancies, and we should tell our patients that with the right guidance, the majority of patients can successfully raise a family. But there are some people who can't. Lupus can affect fertility, and some particular types of lupus are prone to miscarriages, and that leads us to Anna's question. So what would I advise a patient who's had 4 miscarriages with lupus? Firstly, the person should be under the care of a rheumatologist to determine whether they've got a particular type of antibody that's associated with pregnancy loss. Now, if they've got this particular antibody called antiphospholipid antibody, then a treatment with anticoagulation under the careful guidance of expert clinicians can be associated with successful pregnancy outcomes in a significant proportion of cases. Now, we don't like giving anticoagulate therapy to patients who are pregnant, and that's got to be monitored extremely carefully. However, in the right hands and with careful observation, we can have good outcomes, and we've had a number of those sort of outcomes here at Monash. Now, the next part of the question is, are there trials for pregnant women? There are trials for lupus pregnancies that are happening around the world. There's not currently any of those trials here at Monash, I can tell you, even though we've got a very large pregnancy service and a very large lupus service. We don't currently have any treatments under trial for lupus pregnancy, but I can tell you that trials of these anticoagulant therapies are underway around the world, and we should have the results within the next year or so. So that's the end of that question, and so I'm happy to see if there are any other questions.
Eric, I'll just chip in there. I have a question.
Yeah.
You mentioned earlier about that probably referral to a specialist is best to really confirm a diagnosis of lupus. If you were a GP, at what point or what signs and symptoms would really sort of think that, time for a referral and this person may have lupus?
Okay, that's a great question. So there's clusters of symptoms that suggest the presence of inflammation, such as skin rash, joint pain, and tiredness. So the presence of skin rash, joint pain, and tiredness suggests several possibilities. Viruses can cause those symptoms, but immune diseases can cause those symptoms. And there's a simple blood test called the ANA test, which, although it's positive in a lot of people who don't have lupus, it's almost never negative in people with lupus. So if a patient has skin rash, joint pain, tiredness, and a positive ANA test, then that's a patient who you would think has suspected lupus and should be seen by a specialist. And most GPs will be very well aware of this type of symptom cluster. Now, the problem is that tiredness and aches and pains are incredibly common symptoms, and Jen, you would know this at Move better than almost anyone. These are very common symptoms in our community, and most patients who are tired or who have aches and pains don't have lupus. But the cluster of aches and pains and tiredness with other symptoms, especially skin rash, and especially in the presence of tests that show abnormal antibodies, can shed light on the possibility of lupus as an explanation for the problems.
Thanks, Eric. Now, in the event of no further questions coming through, can I ask people to type in their questions now if you have any last-minute questions for Eric? If we have no further questions, though, Eric, I'd really like to thank you for an incredibly honest presentation tonight. I mean, it's such an interesting area, and your resilience is to be admired with, as you sort of say, the sort of one step forward, two steps back often in working with patients with lupus, and really to hear your the importance that you place on the patient-related outcomes as well is fantastic. So it looks like we're just getting messages to say excellent presentation, which I concur with completely. So on that note, Eric, thank you very much for giving us your time, especially after flying in from overseas just yesterday. And everyone, I would like to thank you for joining us this evening. Can I remind you to take a moment to complete the exit survey, which will come on your screens just after we close for this evening. And keep an eye out for our next webinar, which will be held on the 20th July, and which will be about exercise is medicine, musculoskeletal health. So thanks again, Eric, and thanks again, everyone, for joining us tonight. Good night.
Okay. Thanks, Jen. Good night, everybody.